it means your venous return amount is higher. So what happening through superior vena cava and through inferior vena cava, your venous return is really very fast, very high. So preload, the stretch the extent of muscle, during the diastolic phase. So it actually venous return. So here you can see it here. What I'm saying, indicating venous return to the heart. So these two parameters really control a lot, a significant deal of heart failure. So to understand heart failure, you have to be very clear about this concept. Now, with ventricular problem, with venous return problem, what are the presentation will give by the patient? Firstly, fatigue and weakness. What does it mean, fatigue? With very ordinary, there are few classifications of heart failure, phase 1 until phase 4. So gradually patient, they have the compromise of working capability. So you may can see dyspnea even during the rest. So that is the most terminal one. But you can see here dyspnea, palpitation, ascites, raised JVP, dependent edema, everything is coming. So each of the symptom pathophysiology, I believe somewhere in the PBL they have covered it, but most importantly, cardiomegaly, raised JVP, dyspnea, orthopnea, palpitation, sometime abdominal, edema is there, so abdominal distension will be there. So these are the clinical features of heart failure. Now, what really causing all this problem? As I just now I said, for chronic use, hypertension is considered the most common cause for heart failure, mostly ventricular hypertrophy. Yesterday, we discussed how angiotensin 2 contributing to cause hypertrophy of your left ventricle. And hypertension, if it is not controlled, it increase heart rate of the heart. If heart rate is higher, contractility is higher, it means normally heart should pump 120 beat per minute. But if your hypertension is 140, 50, it means workload is much more higher. So this is considered as the single most very important cause for heart failure. Structural changes, as I said, mostly valvular problem, either stenosis or regurgitation. Second most important cause to develop hypertension. Yeah, there is a compromised heart that cannot pump properly. It includes congenital heart disease, some lung disease, diabetes mellitus, severe anemia, thyrotoxicosis, pregnancy. All can cause temporary heart failure or compromised cardiac function. Now, but I would like to prefer categorize the causes like this way: pressure overload. So it means somehow ventricular pressure getting much higher. So what are the anybody can think what really can increase your ventricular pressure? All cause you have to extract from the previous slide, but you categorize in two different ways: pressure overload and volume overload. So pressure, hypertension, actually aortic stenosis give rise to hypertension. So hypertension, aortic stenosis for the most important cause for left ventricular failure. So here pressure going to be mounting in left ventricle. For right ventricle pulmonary hypertension and pulmonary valvular stenosis, same reason. So if you make the logic like this, it's very difficult for you not to understand or not to forget the reason. So these are the pressure overload. If volume overload, it should be regurgitation, right? Mitral or aortic regurgitation. So during systole, valves are not closing, so there will be one second. So volume overload, blood will be reverse back. So regurgitation. Some in case of children, septal defect, right atrium, left atrium, or right ventricle, left ventricle. So atrial or ventricular septal defect. is another reasons for causing volume overload. Pregnancy thyrotoxicosis also, determining the volume overload for the heart failure. So these are the mostly structural causes, most significantly contributing for the heart failure. Any questions so far? Hello.
No, doctor.
Okay. So can we summarize like that? The grossly pathophysiology of heart failure actually, it depends on the workload of the heart. Many times you saw footballer once they come back from injury and without proper rehabilitation or warm up, if they start playing, many football players suddenly they die. They die in the football pitch. The reason their body is not acclimatized with that kind of workload. So suddenly, if it is increased, they actually pass away. So suddenly, I cannot run for marathon now without practice. If I try to do so, definitely my heart will collapse. Improper contraction of the muscle, that include many things, mostly hypertrophy. So muscle become heavy and thicker, cavity reduces, and their strength also reduces. Which formula actually define cardiac muscle strength? Can you remember for physiology?
Formula for cardiac muscle. What?
Yes.
Uh,
What is Frank standing law?
Frank Starling law. The uh, contraction of the ventricle is
Directly
proportional to the
endastolic,
stretch of the
endastolic fiber length.
yeah.
So if you experience any kind of MI and if your myocardial cells are not healthy, what will happen? You cannot stress, it cannot be cavity in the full stretch. So if cannot be cavity in the full stretch, definitely diastolic volume will be lesser. So once you have the less diastolic volume, definitely your ejection fraction going to be reduced, right? And thirdly, compensatory mechanism. Compensatory mechanism we already discussed yesterday too, neuronal and hormonal. Now, uh, who can tell me, the neuronal regulation of cardiac function? This is not,
Epinephrine,
yeah,
norepinephrine.
it is nothing but recollection of yesterday class. So baroreceptor mechanism. So what happened? Uh, your heart already, for some reason, maybe you develop newly aortic stenosis. Imagine a situation like that. So if you have a baru or not just acute onset of aortic stenosis, what will happen? Ventricle cannot opening, eject the blood. So your carotid artery will sense there is a decrease in blood pressure. So carotid artery don't know that it's a mechanical blockage of your aortic valve. But carotid artery going to sense you have less blood pressure. So what will happen? Carotid artery will send impulse to vasomotor center. The body is going for hypotension. So please release further noradrenaline. So initially, this is the most dangerous situation, compulsory changes in the heart at the acute phase or beginning phase of the heart failure. So what happened? Because of mechanical error, mitral stenosis, aortic stenosis, you are decreasing in blood pressure. So what happened? Baroreceptor will increase sympathetic flow, increase noradrenaline. It going to improve cardiac function or further deteriorate cardiac function? Hmm? It will,
For parasympathetic, is it?
yeah, it will deteriorate cardiac function because your body don't understand the pathophysiology, what happened with the heart, but it again pressing hard to function properly. But it's not the heart problem, not the muscle problem. Soon muscle going to be fatigue. But before they go for fatigue, there will be reflex tachycardia. Severe tachycardia will be there. Not only neuronal, endocrine system also taking part. We already discussed about it yesterday. So once body sensing decreased blood pressure, So they are not only increasing baroreceptor activity, but also they are activating renin-angiotensin activity. So what happening? You are increasing afterload and also preload by vasoconstriction, by salt and water retention. So this is exactly happening at the acute onset of heart failure. First few weeks it is even very worst. So you heart failure, we already decided cardiac function is subnormal. Blood pressure is not enough to meet the metabolic requirement of the body. So what happens? There is a decreased cardiac output. Once you have decreased cardiac output, you have two compensatory mechanisms: your neuronal mechanism, your hormonal mechanism. So what happening? Both the things increase. Try to increase cardiac output, try to increase venous return, which even further worsening the heart condition. So in a acute onset of heart failure patient, these are the compensatory mechanism is going on. So if we get the patient in acute phase, we really have to. Now, if you got a patient like this, should you prescribe beta blocker and ACI inhibitor? Should we?
Yes, you want to reduce the work of the heart.
Yes. But simultaneously, we have to improve the cardiac contractility if required. Otherwise, just use these two drugs, control the compensatory mechanism, patient heart condition will be reversed back soon. Otherwise, you will get myopathy, and megaly as well. Okay. So I think this is the by New York Cardiac Association. They classified 4 classes of cardiac failure, but gradually the cardiac function is going to deteriorate within the patient. So while you are taking history, you really have to find by the questionnaire in which stage they belong. So do you have any problem in ordinary activity? No, I don't have. But if I have to walk a long distance for searching my car in the parking area, yes, I do have breathlessness. If I need to, climb the staircases, I have the problem. So slight problem in ordinary activity. Symptoms occur in exertion, and even symptom can occur at the rest. This is the worst condition. In class 4, usually you will see ascites, dependent edema, and also you will see red JPP because the venous return cannot come to heart anymore. So there will be peripheral congestion. So that peripheral congestion will give you the classical pictures of caput medusa, ascites, and also dependent edema. That is really terminal condition of heart failure. In those situations, the life-saving drug should be loop diuretics because you want to decrease the edema first. Then slowly, if you treat, patient will be quite fine. Now, I think we have few more pictures. So who can tell me what is the difference between these two heart?
One is normal, one is dilated on the left side.
Enlarged, yeah, because mechanical problem, right?
Yes.
Mechanical problem. So maybe ejection is the problem, or maybe there is a regurgitation issue. So heart cavity become lax, muscle become much more fatigue compared to the healthy heart. Now, remodeling, yesterday we already discussed. This is considered as one of the prerequisite of developing heart failure. So, constant presence of angiotensin 2, there will be dilatation and thickening, dilatation and thickening of the left ventricle. So, what will happen? Not only reducing the strength for going for systolic pressure, but also there will be fatigueness of the muscle. So that ventricular muscle will be very weak to pump out the blood. That is actually remodeling. I think if you go for the details, you'll be understanding what it is written here. Now, see very carefully here. Systolic, there are few. Systolic heart failure means heart have a problem in forward direction. It means mostly aortic valve. So ventricular muscle still normal, but venous return cannot eject properly through the aorta. That is actually forward dysfunction or aortic stenosis. But if you see diastolic heart failure, mostly dilatation and thickening. Thickened and steep ventricles. So this is diastolic. So what happening? Filling time is much more poorer. Cavity is so smaller so that the diastolic amount of blood will be less. So let's go through. Systolic dysfunction means forward failure. Inadequate forces generate or mostly aortic stenosis is there. So what happened? It is responsive to inotropic, means drug that can increase cardiac contractility. Ejection fraction is significantly low here. So either your ventricular muscle are lax and fatigue, or there may be a aortic stenosis. Diastolic dysfunction means inadequate relaxation because mostly hypertrophy. That is the most common reason for diastolic dysfunction. So during diastole phase, ventricle cannot produce enough cavitation to deposit the required amount of blood we need. You can see here. So this is the picture of diastolic dysfunction. You can see significant thickening of the ventricular muscle, both right and left ventricular muscle, including the interventricular septum. So heart cavity really become very smaller. High output failure means increased demand of body, especially severe anemia. So everything is normal, but there is a tissue hypoxia. So what happened? Heart constantly keep on pumping. Hyperthyroidism, where body increase the demand and also atrioventricular shunt, they are also producing high output failure. Now, very important, acute clinically actually you will get patient with acute heart failure or chronic heart failure. That is systolic failure, diastolic failure, or high output failure for your understanding, mostly for deciding your medication. But clinically you will get patient with the acute heart failure. I don't think so many of you will be that much lucky to get a acute heart failure patient if you don't work in cardiology department. If you're not a cardiologist or if you're not training, posting in cardiology faculty, it is very difficult to see acute heart failure. Most of the time in internal medicine world, we used to find chronic heart failure for many reasons. It can be small children followed by the rheumatic fever. It may be a person, uh, adult person because of chronic inflammatory calcification. Chronic heart failure is much more common, you can see, because many acute heart failure patients, they are dying even within the ambulance van. The reason, massive cardiac myocardial infarction, or sometimes with severe or grade 3 hypertension, there may be rupture, especially rupture of aortic valve or even aorta. That is quite common. If you search in Google, you'll be seeing there are a lot of patients in acute heart failure. It developed because of grade 3 hypertension, and there is a rupture of aorta because of very high aortic pressure. So these two, if you are very lucky, you can see, but very most of them actually they die. They pass away with acute heart failure. It will give you so small amount time to react. But chronic heart failure with this classical presentation, dilated cardiomyopathy, you will get a lot, because it's not only the cardiac problem, even lung problem also sometimes may can cause secondary cardiac function abnormality. Chronic is very common in respiratory system, in internal medicine, you'll get a lot. But in those cases, mostly actually occurring valvular diseases or some myopathy. So chronic heart failure, you can see a lot, and chronic heart failure patient will give you all those symptoms: dyspnea, palpitation, orthopnea, ascites, raised JBP, right hypochondrial pain. All this you'll see with chronic heart failure patient. Okay. Now, you really have to think when you have received the patient. Treatment totally depend on in which phase your patients are coming to you. Say, for example, you are getting patient in acute phase, then your thinking should be how to reduce compensatory mechanism of the heart, because those compensatory mechanism eventually going to worse the heart condition. If you are getting patient in chronic situation, then you have to think how I can improve cardiac contractility slowly. So heart failure, we already decided patient cardiac contractility is compromised. Patient cardiac output is not enough to meet the metabolic requirement of the body. Now, once we thought of cardiac, output, now we have to think what actually we have to decrease the preload of the heart, right? When venous return, okay. Then we have to decrease afterload of the heart. So aortic regions and also this should be right. This should be right. So treatment strategy depending on whether you want to focus on the contractility of the heart. Um, so
Doctor.
my advice before you go for management, you have to think, give yourself 2 minute time. What actually you want to do? Firstly, definitely it is a bit complicated and multi-organ involved condition. Most of the time, not only a junior doctor can tackle all this, but you have to sit for exam, you have to see many patients in year 3. So firstly, you have to think about cardiac contractility. Maybe initially you have to decrease cardiac contractility, because if you are getting a patient in compulsory phase, they will have super high contractility. You will get a tachycardic patient if your patient is coming during the compulsory phase. Same time, during compulsory phase what happening, their afterload, their preload is already increased, so you have to decrease it. Okay. Again, no, you have to be really rationalize patient heart rate and rhythm. So if you are getting during chronic phase, actually you have to increase it. But if you are getting in acute phase, you have to decrease it. So I cannot really say cardiac contractility in a very static way of treatment, because later on when we're going to discuss the drug, we are going to teach actually both. Okay. So we assuming we are getting a patient in a chronic phase, because as I said, acute phase is not so easy to get, and most of the time actually they don't survive. So this class focus mostly going to be on the chronic phase treatment. Now, it is very assumable you have to really reduce the workload of the heart. So how to reduce the workload of the heart? Adjustment of the heart rate. Again, I'm telling when you are getting the patient. Okay, so you have to, if bradycardia, you have to give stimulant drug to become normal heart rate. No objective to increase the heart rate, but rather we have to normalize the heart rate. Cardiac failure patient and renal failure patient, actually they take water with a spoon. Their daily intake of water and sodium is very measured. Okay, we have to give diuretics if patient with ascites and other problems. So restriction of sodium, giving diuretics, actually what I'm doing, I'm reducing blood volume. If I reduce blood volume, it means I'm decreasing the preload of the heart. I must have to give angiotensin converting enzyme inhibitor. Why? Who can tell me why? Who can tell me?
Because it also stops angiotensin too.
Yes, very good. Because angiotensin 2 causing both, contributing both for preload and also afterload. One added advantage, you are going to reduce the dilated cardiomyopathy. That is the biggest advantage of ACEI inhibitor. This is one of the prototype of drug. It actually can increase the heart rate, because if you get a patient very compromised heart, maybe phase 2 or grade 3 heart failure, you will see they have bradycardia. Okay, so then you have to increase or adjust their heart rate. Okay. Now, there are actually three drugs we are giving or improving the cardiac contractility. There should be some medication for improving the cardiac contractility. Please, for a moment, you delete from your brain. I discussed about there should at initial 1 week there may be possibility of tachycardia. You ignore that part. Otherwise, you'll be seriously confused with the class. That was compensatory mechanism, and I said it is very unlikely you may can get a patient at that phase, but mostly patients are coming to you as a chronic heart failure. So now onward, my most of the discussion going to be a chronic heart failure. So a chronic heart failure patient, what is your expectation? Heart rate is high or low? Tachycardia or bradycardia?
Tachycardia.
Chronic heart failures.
I think bradycardia.
Yes, heart rate is low. That's why, the circulation, the pumping problem is there. So in chronic heart failure patient, mostly they have the problem with the bradycardia. That's why you need a positive inotropic drug. What does it mean? The drug can cause increased force of contraction, increased heart rate. You need that kind of drug. Okay, so what are the drugs we can use for positive inotropic effect or improve cardiac contractility? Firstly, digoxin and digitoxin. It is using, I think, 200 years now already. There is another drugs, phosphodiesterase enzyme inhibitor. In this room, is there anybody who can tell me the role of inositol triphosphate? Out of the students here, is there anybody who can tell me the role of IP3?
The second messenger.
What it do? What is the prime function of IP3?
Increase intracellular calcium.
Excellent. If you increase intracellular calcium, what is the benefit with the heart?
You have better contraction, stronger
Yeah.
contraction.
Excellent. So what happening? Drug category 1 and 2, so cardiac glycosides and phosphodiesterase enzyme inhibitors, both of them, they supply more intracellular calcium. So if you can supply more intracellular calcium, you are enhancing cardiac contractility. On the other hand, beta-1 agonist, dobutamine, it is very specific agonist on beta-1 receptor. So if you can stimulate beta-1 receptor, you can produce more cardiac impulse, right? Boleta.
Yes.
So if you can improve more cardiac impulse, it is tachycardia or bradycardia, or you are increasing cardiac contractility. Pahamta. Pahamta. Okay. So these are the drugs we are giving to improve force of contraction if we receive a patient with severe bradycardia and heart failure. Mostly it is during the chronic phase. So first aim we have set, we have to improve cardiac performance. We have to improve cardiac contractility. So I think A-level boy also know, a A-level student, how to improve cardiac contractility. Sir, you supply more calcium to the muscle, cardiac muscle. So who are the two drugs? So cardiac glycosides and also phosphodiesterase enzyme inhibitor. Those are the drug that can supply more calcium to cardiac muscle. And another way, just stimulate beta-1 receptors so that there will be improvement in the cardiac function. So this is actually prototype drug. This drug has a very wonderful story. Maybe today we cannot finish, so we have to be a little bit chapet. But this drug actually originated in UK, and there is a very wonderful traditional history about this drug. One dying patient, one village doctor, he saved the person, a lady, and following since that day, it became the part of management of very important drug in management of uh, cardiac failures. Okay, so cardiac glycoside stimulate myocardial contractility. We already said that. So what happened? Once you can, especially ventricular contractility, if you can improve, there will be improved ventricular emptying. So it's going to enhance cardiac output. it's going to increase ejection fraction, isn't it? So what happens? Slowly, it will reduce the cardiac size. It is used in acute, as I said. Nobody know actually in which condition of heart you are getting. If you are getting in compulsory phase, is different. If you're getting in compromised phase, it is different. So it can be used acute or chronic, but depend on what is your patient condition. Okay. Now, advantage is there's two main advantages. It is an inotropic drug, increased contractility, and you can give this drug orally. Most of the digoxin actually we are giving orally. Disadvantage: this drug is very very toxic. So you have to really give a small dose. If patient heart condition is too bad, you cannot improve the dose. Always you have to follow the therapeutic window. So correct dose, correct therapeutic blood level, that ranges are uncertain because different patient giving different response. This is chemical structure. Okay. This is the source, natural source of this drug. Half-life is 1.5 days, or it can go even 5 days. So one drug for 1 week should be okay, because as we said earlier, it's a very toxic drug, so you have to be very careful of using this drug. Metabolism, I think nothing significant. It is metabolized in the liver and eliminated by a kidney. Now, who can describe this curve? Is there anybody who can describe this curve?
This is the ventricular, the electrical activity in the ventricle.
So it is action potential of a ventricular muscle, right?
Yes.
How many phases are here?
0, 1, 2, 3, 4.
0, 0,
And then 1, 2,
3.
3, then 4.
Okay. So rightly he said, I think how many of you know, I don't know, but zero phase is very, very important, because this zero phase leading this ventricular muscle from resting membrane potential until the spike potential. In zero phase, there is a massive rush of sodium from extracellular to ventricular muscle in zero phase, followed by there should be a small and slight repolarization phase, mostly exit of potassium. Actually, here is a sodium potassium pump. So, there will be entrance of sodium and elimination of potassium. Very important, this small pump. So following phase 1, there will be a plateau phase. It means entrance of calcium. So after phase 2, what happened? There should be a rapid repolarization or elimination of potassium. In phase 4, there should be entrance of sodium, and heart is getting ready for the next action potential. What happened? Okay, that's all. So how I lost one slide? Okay, kindly you notice here, because if you understand this slide, drug use for arrhythmia, it will be much more easier for you. So we have 4 phases. So phase 0, what is actually in phase 0? What happened?
Rapid depolarization due to influx of sodium.
Rapid influx of sodium, right? So sodium in phase 0, did it fulfill our criteria?
Yes.
Yes. So in zero phase, we saw from resting membrane potential, lot of sodium entered, and we got a spike potential. After zero phase, phase one. What happened to phase one?
Initial repolarization.
So in phase one, what happened? There will be elimination of potassium. So elimination of potassium is caused initial repolarization or slight repolarization. So please remember this one actually governed by your sodium potassium pump. Simultaneously, the amount of potassium is going out, sodium should be coming in. So what happening to phase two?
The plateau phase, entry of calcium.
Very good. So plateau phase, there should be an entry of calcium. Clear? Panta. Okay. Now, who can tell me what is the fate of this calcium? Why calcium suddenly? Other nerve muscle, nerve fiber, muscle fiber, RBC, any other excitable tissue, there is no plateau. Panta.
Yeah, faham.
You have only plateau in heart, right?
Yes.
Why? What is the fate of this calcium?
The plateau is because of the opposing movement of potassium outside.
To give it enough time for ventricle sealing.
No, calcium will not do that.
Release calcium from sarcoplasmic reticulum.
Yeah, actually, initially going to deposit, later on, it's going to be released and causing muscle contraction. So that's why the calcium and the plateau phase, because you need calcium to go for cardiac muscle contraction. So after phase two, there should be a phase three where potassium going to be eliminate largely from the body. So phase three. So phase four is entrance of sodium again. Sorry, potassium with the sodium potassium pump. Okay, so calcium went to sarcoplasmic reticulum. Then when needed, calcium will go and cause muscle contraction. Now, if there anybody from your physiology will tell me what is the relationship between intracellular sodium and intracellular calcium, is there anybody who can explain me that? Is there anybody?
The influx of calcium is driven by the sodium gradient due to the calcium-sodium exchanger.
Very good. Where you notice it? Did in my picture anywhere you saw the calcium sodium calcium exchanger?
The purple round on the
Yeah,
right.
right. So in case if I block this sodium channel, what will happen? Calcium can go out?
Cannot.
No. So exactly digoxin is the drug is designed to block this sodium channel. So what happens if this sodium channel is blocked? If the sodium channel is blocked, lifelong calcium concentration will be higher, and excess concentration of calcium eventually will bring further calcium into the cytoplasm because outside the blood there will be increased positivity. So to compensate that, there will be much more rush of calcium from extracellular fluid to cytoplasm, especially cardiac muscle cytoplasm. So blocking this sodium, it interestingly increasing calcium concentration. That what I want for a cardiac failure patient. Pamta, Pamta.
Um,
So the digoxin drug blocking sodium calcium exchanger so that sodium will be not exchanged in with the calcium, so there will be excess concentration of calcium. Excess concentration of calcium will cause extra cardiac muscle contraction, so improvement of cardiac function. So this is, I think, here. Bind with the sodium potassium pump, inhibit the pump, increase intracellular sodium, inhibition of the sodium calcium exchanger. So just now the purple pump. So if you inhibit sodium calcium exchanger, what will happen? There will be increased concentration of calcium. If intracellular calcium is higher, it will go to sarcoplasmic retinaculum and it will cause force of contraction. Got any question or not? Hmm? So if you have free time, this is the mechanism of action. You just can write it. So what happened? Blocking sodium potassium pump will increase the concentration of so you are blocking this pump also. So what will happen? There will be no exchange of sodium calcium. So blocking sodium, actually it will remain the calcium concentration. So if you can keep the calcium concentration, extra calcium will come to sarcoplasmic retinaculum, and this sarcoplasmic retinaculum calcium, it will take part in the contractile cascades of muscle contraction. So this is the mechanism I think you can study. Okay, contraindication, especially definitely if there is any obstructive cardiomyopathy, even electrolyte imbalance also, you cannot give this drug. Adverse effect, mostly hypokalemia is electrolyte imbalance, especially hypokalemia is very important adverse effect. Rather than that, gynecomastia and secondary, it can cause actually heart block. So if there is a history of any block, you cannot give this drug, cardiac glycosides. Now, who can tell me, name 3 group of drug who can improve cardiac contractility? State 3 groups of drug that can improve your cardiac contractility.
Cardiac glycosides.
Very good. Lagi?
Phosphodiesterase.
Enzyme inhibitor, who is going to increase inositol triphosphate concentration so that you will get extra calcium. And finally, we can use beta agonistic drug. Faham? So these 3 drugs still we are in objective 1, improve cardiac function. So second group of drugs should be phosphodiesterase enzyme inhibitor. So normally phosphodiesterase enzyme responsible for degradation of cyclic AMP. So if you actually degraded cyclic AMP, cyclic AMP, it has 2 functions. One pathway, it is going for dephosphorylation of myosin light chain kinase, but that is mostly with the endothelial muscle. But in cardiac muscle, what they do, it's going to increase the concentration of inositol triphosphate. So if you have more inositol triphosphate concentration, you'll have more calcium. I think I have mentioned somewhere here. So if you can inhibit phosphodiesterase enzyme, there will be increased cyclic AMP. That cyclic AMP, because G protein, it has 2 pathway. One is second messenger pathway, another is IP3 diacylglycerol pathway. So here, your cyclic GMP going to improve or increase concentration of protein kinase A by actually inositol triphosphate. So that will enhance the entrance of calcium through the L type of calcium channel. So increased cardiac output, and also there will be decreased peripheral vascular resistance, which is both good for you. So you are increasing cardiac contractility for a cardiac compromised patient. Finally, beta-1 agonist. It will be stimulating your beta-1 receptor, so there will be increased inotropic and increased chronotropic effect with the patient. So far, I think at your level, even year 3, everybody will be looking for this grade 1 or first objective, how to improve cardiac contractility. So 3 group of drug, digoxin, phosphodiesterase enzyme inhibitor, and beta-1 agonist. Digoxin and phosphodiesterase enzyme inhibitor, both of them have similar kind of activity, increasing intracellular calcium concentration. On the other hand, beta-1 agonist acting directly stimulating beta-1 receptor, which you already know from yesterday class. So beta-1 agonist, as I said, the same thing. It will improve the inotropic and chromotropic effect. Now it is kind of customized drug. You getting patient in which situation? Example, you got a patient with massive dilated cardiomyopathy. there is a huge thickening of the ventricular muscle, very poor ejection fraction. So in those cases, your drug of choice should be ACI inhibitor. Okay, you got a patient with grade 4 in during resting also there is a dyspnea, patient having massive ascites, severe dependent edema, and patient has to admit into the intensive care unit. The first line drug is actually diuretics. Okay, beta blocker, all that actually is customized really, but two obvious drugs are diuretics and ACI inhibitor and angiotensin 2 receptor blocker. Beta blocker mostly if you got a patient in compulsory phase, because already a person who had just now we try to improve cardiac function by stimulating beta 1 receptor. Now, what is the justification I'm proposing now here? Please go and check with the Davidson also. It is there. But I have to understand I'm getting the patient in which phase. So beta blocker, mostly we are designing if our patient are getting during compulsory phase, neuronal and endocrine compulsory phase. At that time, it is indicated. So as I said, for chronic heart failure patient, you cannot write all the drug. Exactly, your cardiologist will choose a drug, what is required for the patient. But when you are teaching in pharmacology, we are giving you the holistic picture in every possible situation. So if you ask me when I should give diuretics, yes, if your patient having massive edema, if they're having abdominal distension, caput medusa, and also dependent edema, raised JVP, please start with the diuretic first. But no edema sign, patient come only with a dilated cardiomyopathy, in grade 1, grade 2 heart failure, your best choice of drugs would be ACI inhibitor and angiotensin 2 receptor blocker. Beta blocker, if you are getting patient exactly in the compulsory phase, where there is a decreased cardiac output, but reflex tachycardias are there. So at that time, beta blocker will be your drug of choice. So diuretics increase water elimination from the kidney. So main focus decrease blood volume. So it going to decrease the ventricular preload. Okay, so if you decrease ventricular preload, there will be decreased venous return. Eventually, you are reducing cardiac workload. Okay, so nowadays after furosemide, loop diuretics, some people they using aldosterone receptor antagonist, macam-macam, but still classical mainstream drug for decreased cardiac workload is the loop diuretics or furosemide. So now, have you ever heard about loop diuretics?
They act on the loop of Henle.
Ascending limb of loop of Henle, and they are inhibiting the 2 potassium and chloride calcium 2 potassium chloride channel. It means actually the main reason they cause diuresis, they stopping sodium reabsorption. Remember at somewhere I said the heart failure patient, their water consumption also calculated, their sodium consumption also calculated, because they already know how many liters blood actually can pump by your heart. It is coming through echocardiogram. So after that echocardio report, they exactly going to calculate how much water and salt intake you should have. If you are having extra salt and water intake, definitely they will be using these loop diuretics to pump out those extra salt and water. The reason they want to give enough rest to your heart. They don't want to overload with the venous return. If it is overloaded with the venous return, what will happen? Your right heart pressure going to be increased, isn't it? So using loop diuretics, decreasing workload of the heart by reducing preload and reducing venous return. Okay. So mechanism preload reduction of excess plasma volume and edema fluid. It will eliminate from the body. After that, lower the aortic pressure actually. Sympathetic reduction of facilitation of sympathetic nervous system. So they are proposing there are some sympatho sympathetic nervous inhibitory effect there as well. So that's why diuretic come first. If anybody asks you what is the maintenance therapy for chronic heart failure, one drug. If one drug, diuretics. Two drug, ACI inhibitors. Panta. You cannot save a patient without diuretics with chronic heart failure. Vasodilator nowadays actually nobody using, especially nitroprusside for severe cases, arterial and vein dilator. It is almost same like AC inhibitor because the reason is reduce total peripheral resistance. Now I have a better drug. Previously they used minoxidil. Previously they used sodium nitroprusside because at that era I didn't have ACI inhibitor. Once I get an ACI inhibitor who is not only reducing preload and afterload, moreover it is also reducing angiotensin 2 and improving cardiomyopathy, why I should go for vasodilator. So normally we are using actually now we replace all the vasodilator with the ACEI inhibitor. So reduce total peripheral resistance. So decrease preload and afterload, decrease blood pressure. See here, decrease sodium restriction, reducing preload, reducing afterload, also reducing sympathetic outflow. Excellent drug for long-term remodeling of the heart and blood vessels. So year 3, year 4, anybody asking you, tell me the drug used for heart failure, diuretics, ACE inhibitors. Just then keep quiet. They may can ask you why you want to use ACE inhibitor. Because if I use ACE inhibitor, it's the maximum benefit for the heart. How? Because it reducing afterload, so improve ventricular left ventricular function. If reduce preload, so improve right ventricular function. Moreover, it has an excellent efficacy on reducing the dilatation and thickening of the ventricular muscle. So to me, if I can give ACE inhibitor first, I'll give first. But if patient with the edema, I have to choose with the diuretics. So mechanism: reduce afterload, reduce preload, sympathetic nervous system inhibition, and reduce cardiac hypertrophy. If you cannot mention it, nobody will make you pass with ACI inhibitors. Receptor blocker also same, losartan, because ACI inhibitor having dry cough problem, so that's why you have to go for angiotensin 2 receptor blocker. Beta blocker, as I said, there are some controversy. Some people, they don't want to accept why you are including a beta blocker for a cardiac patient. If you're a smart student, your answer should be, sir, I will be considering beta blocker if I get a patient during compulsory phase also. Otherwise, your ACI inhibitor is more than enough. Everything in one drug, if you're looking for, is ACI inhibitors. So you know already mechanism. Vasodilator, I think nowadays nobody using. So that's all about heart failure. Now,
Doctor,
hmm.
so during the compensatory phase, you expect to see tachycardia, right? And after that, when everything fails, to become bradycardia, is it?
Yes. Let me go to that slide here. This phase is the most dangerous phase. At the beginning, during the onset of heart failure, definitely there is a decreased cardiac output, right? But decreased cardiac output eventually compensation increased cardiac output, but already pathology is there. Already mechanical or volume defect is there. But what happened because of forcing by these two mechanisms, heart try to compensate with the increased cardiac output. At that phase, we should use beta blocker because we already by our ECG and echocardiogram, we already know what is the pathology with the heart. So we don't allow heart to go for these compensatory changes during the heart failure period. It is really controversial to use beta blocker in heart failure. But if your answer is ready, if you can give the logic, then it is acceptable.
Doctor. But so once after the compensatory phase, when it becomes bradycardia, then only we give digoxin.
Yes, digoxin also. As I said, cardiac failure is a very complicated. It may be because of other organ. Pulmonary edema itself also can cause your congestive heart failure, right? Because in pulmonary edema phase, your right ventricle cannot work. You cannot pump any blood from right ventricle to lung. So you have to improve then pulmonary edema first. Then automatically your cardiac function going to be improved. Paham? So, but the fundamental learning about heart failure, we are assuming we get a patient who have a very poor cardiac function. That should be our at year 2 level of thinking. So poor cardiac function, how to improve? So we have two category of drug: initiation therapy, maintenance therapy. Digoxin nobody using for long time. It is only to activate the heart, the keep on going the heart function, followed by either diuretics or ACI inhibitor. They have to continue for lifelong. And also, if there is any other secondary reason, you have to correct it. But nobody is giving for long time digoxin, unlikely. Clear? So two category drug. One is improvement of cardiac function. Second is reduce the workload of the heart. So four medication I discussed, there are two actually objective. First, you have to improve cardiac function by digoxin, digitoxin, phosphodiesterase enzyme inhibitor, and also by beta-1 agonist. Improve cardiac contractility. Another group of drug we have discussed to decrease the cardiac workload. So how to do that? Reduce afterload, reduce preload, decrease sympathetic activation. That is, we are achieving by number one drug ACI inhibitor, number two drug diuretics. If there is a edema, then your first preference drug should be loop diuretics. Clear? Paham tak? So I can go for next topic for anti-arrhythmic drug.
Can, doctor.
And I think today class percentage is very low, only 34 students. Is it the timing was not suitable with them?
I think so, doctor.
I had to for the student interview, for new intake, student interview was there. Okay, so I'm going for anti-arrhythmic drug. Anticoagulant, I think I already gave the slide. Maybe you can do Sindiri. So arrhythmia actually is very, very easy topic. What is arrhythmia?
Abnormal rhythm.
Abnormal rhythm. It may be bradycardia or it may be tachycardia. So if it is predominantly bradycardia, probably patient is going for heart failure. Even constant tachycardia also can go for heart failure. But a developed heart failure patient, mostly they have bradycardia, not the tachycardia. Okay. So what happened, as you just now said, arrhythmia is the abnormality of the heart rhythm. So either it can be bradycardia or it can be tachycardia. If it is bradycardia, we will be referred to drug we have been used for heart failure, especially digoxin, digitoxin, phosphodiesterase enzyme inhibitors, and beta-1 agonistic drug. So your arrhythmic patient, if they having mostly bradycardia issue, we refer to previous group of drug. On the other hand, if you got a patient with, having fast heart rate, they have tachycardia, then this group of drugs we're going to use here. Now, physiologically, we already know some part of the cardiac muscle action potential. Mostly In a resting phase, SN node normally is minus 40, but myocardial cells are minus 90 millivolt. So what happened in the resting phase? How they remain in the resting? Because there is more exit of potassium, isn't it? Through the sodium potassium channel. We already know phases involved in the cardiac action potential. Those are phase 0, phase 1, phase 2, phase 3, and phase 4. So now who is actually generating cardiac rhythm?
SA node.
Okay, if you cut one of your finger, what will happen? Can you see any contraction, any response in that dissected part of your body? Any viscera, stomach, spleen, lung. If you dissect them, what do you think? Can they generate their own impulse?
No.
But you saw open heart surgery. From patient, heart is far away, right?
Yes.
Is it heart is vibrating at that time or not?
A bit. Yes.
Yes. Even during cardiac surgery, when they remove heart from the middle mediastinum to the another device, still it is contraction relaxation going on because heart excitation doesn't depend on brain. It has its own system of impulse generation, that is by SN node. It is good and also it may be bad. Let's explore on that part. So SN node is we call it pacemaker, right? It means they can generate their own rhythm. Normally it should be 60 to 100 beat per minutes, isn't it? So during depolarization phase, what will happen? There will be generation and propagation of action potential. It means from SN node, internodal pathway, AB node, then Purkinje fiber and bundle of His. That is the pathway of your SN nodal discharge. So just now what I was saying, you all of you know, correct or not? Betul?
So,
Okay. Now, so we know it is autonomic nervous system mediated parasympathetic system, mostly M2 receptor that is responsible for bradycardia. On the other hand, just now we saw if you want to improve cardiac function, that should be beta 1 receptor. Why it is so important? Because somebody jump from level 10 or level 15. Do you think they will die when they touch the ground, or they may can die even in between the sky? What do you think?
if what we jump from there,
If somebody jumping from 15-story building, so when they should die? They should die when they hit the ground, or even in the midway in the path of 15 to 0 floor, they will die.
when they hit the ground.
Because of vasovagal shock, the M2, it will be so much stimulated, it will totally block a synodal pathway. So that you saw sometimes some of the content in the news, they said, they write a footnote, weak heart people, please don't see it. In newspaper, in Facebook, you saw that restricted news info. Ever you saw?
Yeah, saw before.
Yeah. Some brutal thing, they will put a cover and they will be taking your consent, you are not a weak heart person. What does it mean? It means some people, they may be predominant or more dominant with the parasympathetic system. When you scare, suddenly our heart stop. Why? Because at that time is M2 overstimulation. But if you take caffeine, cappuccino, if you take stimulating drug, cocaine, you are going to stimulate your beta 1 receptor. So today our class, we are not going to do anything with the parasympathetic system. Let it be like that. We don't bother with that. Today class mostly on sympathetic or beta 1 mediated increase heart rate, increase automaticity, and increase AV conduction. This portion we're going to discuss today. So normally in a pulse, what are the things you should check?
rhythm, character, volume.
Hmm? So in a pulse, we try to find actually heart rate rhythm, isn't it? And if it is through ECG, we have to see the origin because cardiac function we can monitor in three ways, either by auscultation with the stethoscope by heart sound or by feeling the pulse. If we feel the pulse, we only can get information about the rate and rhythm. But origin and the prolongation, we have to see the ECG. So, can you diagnose arrhythmia without seeing ECG? Is it possible?
Yes.
So, we need to do ECG to see the origin of this abnormality. Why? Because nodal pathway, it it really spread in many places. It start above the ventricle atrial, right? Then within intraatrial septum, then at the ventricular beginning, and until the terminal part of the ventricle. Origin is very important with selecting medication and also the outcome of the patient. Okay, so I think all of you know ECG health P, QRS. Who can tell me P denote for what?
Atrial depolarization.
Yes, it means entrance of sodium, right?
Yeah.
That is very important for me. QRS?
The ventricular depolarization.
Ion is responsible.
Uh, calcium and sodium.
Excellent. Repolarization is for the potassium, right? We don't bother much if it is not MI. Actually, for arrhythmia, we have to see P and QRS mostly. T, we have to see for MI patient. That is another part. I don't want to discuss that. But today, our focus will be on sodium channel and also calcium channel. Now, why somebody have arrhythmia and somebody don't have? What do you think? Are you familiar with this picture? This is actually physiology. I shouldn't touch.
Not sure.
Hmm?
Not sure what this diagram is.
You never saw this diagram even in physiology. Hmm? Okay.
Supraventricular tachycardia is an arrhythmia which occurs above the ventricles. Examples of supraventricular tachycardias include atrial tachycardia, atrial fibrillation, atrial flutter, atrioventricular reentry tachycardia, AVRT, and atrioventricular nodal reentry tachycardia, or AVNRT. AVNRT is the classic supraventricular tachycardia and is a result of abnormal, unsynchronized electrical transmission from the atrioventricular node to the ventricles. The sinoatrial node is a dominant pacemaker cell in the heart which sends impulses to the atrium, causing atrial contraction. From there, the impulse arrives at the AV node. The AV node conducts the impulse slower before entering the bundle of His, bundle branches, and Purkinje fibers, where the impulse travels rapidly, resulting in AVNRT, the atrioventricular nodal reentry tachycardia. And there are two main types of AVNRT. The slow, fast AVNRT accounts for 90% of AVNRTs. Impulse travels slow along the slow pathway and fast along the fast pathway. The impulse traveling down the fast pathway will eventually excite cells at the bundle of His, but also in the slow pathway as well. The fast impulse will thus cancel out the slow impulse in the process.
Okay. Have you got actually what happened here? Why this portion of the synodal pathway is highlighted? What happened here?
Maybe there's ischemia.
Excellent. Actually, if there is ischemia, myocardial infarction, and some of the myocardial cell went for fibrosis, what will happen? Definitely, impulse transmission will be slow here. Correct or not?
Correct.
Yes. So what happened? This slow phase, just now you saw in the video, the first normal pathway, it will go back. So normally they should actually meet in this direction. Normally, there should be a junction point from this side as well. But because of blockage, it is split into two halves. One go here, another go here. So what happened? This first impulse never terminating. It keep on rotating into the your AV nodal pathway. Fahamta? It not really neutralizing. If you see, normally impulse come from both direction, you look. But what happened here? It split into two half. First half of the impulse is going in avinodal pathway, Purkinje fiber, and ventricular direction. But another half is split and it never ends. So this depolarization always rotating. So here, re-entry refractory tissue reflect due to the conduction block causes abnormal continuous circuit. So it is never terminate. So this is accessory pathway link atria and ventricle, or even in the Wolff-Parkinson syndrome. So where fast pathway half never terminated, so it keep on recirculate. So sometime it can this blockage is the main responsible reason considering for developing supraventricular tachyarrhythmia. Why I'm discussing supraventricular tachyarrhythmia? Because that is more common and most of the medication is using for that. Ventricular tachyarrhythmia is secondary to valvular, but most of the synodal origin issues remaining within the supraventricular part, which are already mentioned into the video. Okay. So we already know this phase. So what will happen if your first impulses keep on rotating? In which phase of the cardiac action potential you are actually? Zero, one. Hello.
Which phase is what again, doctor?
That never-ending circle rotating in which part of the action potential of cardiac muscle? Which phase?
Phase 0.
Phase 0, because excitation phase. Okay. So phase 0 is the rapid depolarization phase or excitatory phase, phase 0. Phase 1 you already know, partial repolarization we already discussed. Phase 2 is the plateau phase. Phase 3 is the repolarization phase. Phase 4 for refractory period or entrance of slow inflow of sodium. Okay. Now acute management, how can we manage arrhythmia? There should be acute management, prophylaxis, and some non-pharmacological. Any movie you saw, what they do, people are giving massage to the carotid artery. Did you saw? Okay. Next time, if you stress, if you want to control your tachycardia, you give either one, not both carotid artery together, then you will fit. One carotid artery massage. Actually, it can reduce your heart rate because it will inhibit your vasomotor center and decrease the beta 1 stimulation. So that is non-pharmacological intervention. But pharmacologically, we have few group of drugs here. So phase zero correspond with the class 1 of, this is for red one is for pharmacological classification. And for year 2, my request you actually restrict until here, because most of the drug mechanism you already read, or some of the drug in upcoming block you're going to be study that. But understanding the phases is very, very important. Can I say pharmacological classification 1 is equivalent of physiological 0 phase? Is it same?
Same.
Yes, because they block sodium.
In phase 0, can I say this is depolarization phase?
Yes,
What causing depolarization?
sodium.
So in class 1, sodium channel blocker. Paham tak? Now, to me, that is more important. Why I have to block sodium? What is the reason? And which group of patients should take class 1 drug? If pathophysiology related to blockage theory, right? The re-entry phase, found that. Okay, so class 1 drug, there are 3 classification. Lidocaine is a local anesthetic drug. I don't know in CNS you have studied or not. Fleacyanide, quinidine, procainamide, and diphosphoramine. There is no reason at this moment to go for individual all these drug. But as a at this moment, you should remember why you want to block sodium channel. Because if you block sodium channel, you can inhibit cardiac action potential. If you inhibit cardiac action potential, definitely you are reducing the generation and circulation of fast impulses. You are controlling that. So class 1. Okay. Now let's go to class 2. What is class 2 here? Entrance of what? What will happen if class 2 is, remember there is a sodium potassium pump, right? Entry of sodium,
Yes.
elimination of potassium, right?
Yes.
And did I mention in the previous slide, phase 4 actually refractory period?
Yes.
What is refractory period?
A period where another action potential that can be generated.
Hmm? What is refractory period?
Relative or absolute, doctor? Which one?
You don't know what is refractory period. Heart muscle, it has 2 action, right? Contraction and relaxation. Systole or diastole, right?
Oh yes, during diastole.
What is the systolic duration? What is the
Phase 0.
duration? Systole for how many millisecond?
150 milliseconds.
Azim. Cardiac cycle is 0.8 millisecond duration. Among that, systole is 0.3 and diastolic is 0.5. Clear? Okay. Once you go ready for systole, do you think if however is your cardiac contractility, however tachycardia you are, you can interfere systole? Always heart will complete systole first, then it will go for diastole. Anta.
Ah,
Yes. So that is the gap. Actually, there is no gap between cardiac function. Systole, diastole is simultaneously happening. But systole is for 0.3 second, diastolic is for 0.8 second, isn't it? So when you are in a systole, you cannot cause diastole. When you are in a diastole, you cannot reintroduce another systole. So that is refractory period. Here, but refractory period can be in arrhythmia, it is more or less refractory period. Resting time for heart is more or less in arrhythmia.
Less.
Very less, right? That's why ventricle don't have enough time for filling. So here, that sodium potassium phase, if you slow your SA note, If you try to prevent SN node discharge, it will get enough ventricular filling time. Refractory period going to be prolonged. So that's why here in during sodium potassium exchange, you are prolonging it. Also very important. Class 3 you already know, right? This is for upper. Potassium channel blocker, right?
Yes.
Okay, class 3 actually is the phase 3 blocker, or 0, it will determine the distance between phase 0 to phase 3. Phase 3 is the potassium channel blocker. Phase 4, it means actually drug class 4 means phase 2 blocker. What is phase 2?
Plateau phase.
So you for a arrhythmic patient, do you want more calcium?
We want less calcium.
You want less calcium. So should you give a blocker?
Yes.
Yes. So that here, calcium channel blocker. So now should I, but drug example will be different. Now you have to go for cardioselective like verapamil and diltiazem, but mechanism is same. It's going to restrict the entry of calcium into the ventricular muscle. So to me, I think for your level, and I don't know how they said the learning objective and all that, I really don't want to burden yourself much, but I think you just read this slide for anti-arrhythmic drug. So why you are saying class 1? Firstly, you read this slide. Actually, if I'm you, I'll be reading this slide, followed by I'll be reading this slide. Enough. Remaining all class, I have explained mechanism of action of quinidine, mechanism of action of lidocaine. I don't think so it is much required at this moment. Beta blocker, potassium channel blocker, calcium channel blocker already been done. Okay. Any question? Because I think student number also a bit less, so most of the people are busy. So I don't know, is there any schedule for any other block?
I think there's one more topic on anti-epileptic agents.
So that is very easy one. Very easy. But rather, I think antipsychotic, antidepressant, sedative hypnotics, epilepsy. If you ask me clinically, most of the epileptic treatment actually nowadays we are doing by sedative drug. A typical epileptic phenytoin, carbamazepine, clinical use very, very low because those drugs having a lot of adverse effect. And now new improved local anesthetic drugs, sedative hypnotic drugs really can replace existing anti-epileptic drugs. Anyway, you suggest later on I'll give my opinion. Okay.
Right, doctor.
Okay, thank you very much. Thank you for joining the session.
Thank you, doctor.
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 Yeah.